That is a good question. It's unfortunately also a question that we are not capable of answering completely. We have performed a systematic review where we have evaluated the risk of wound complication after second-degree tear and episiotomy. And we found the risk to be between 0 to 30%. So that's quite a huge interval. When we looked into the review, we also saw that studies that had a clinical evaluation 1 to 3 weeks postpartum had a higher complication rates than those that looked at registers. So it looked like if we don't look for the complication, we don't see them. In the repair study, we saw that if we do not give the women antibiotics, we had around 17% of the women who had a clinically relevant wound complication. So quite high complication rates after what we usually call normal obstetric tears. In our study, in the RCT study, we randomized 442 women into receiving either 3 tablets of antibiotics or 3 tablets of placebo. And then we saw them after a week to evaluate the healing status. We saw that with a broad definition, including a lot of wound complication, we had a decrease in wound complication, but it was not significant. For clinically relevant wound complication, we saw that in the antibiotic group, it decreased from 17% to 9%, and that was significant. Further, women in the antibiotic group reported better self-reported health. They had fewer additional antibiotics prescribed, they had fewer extra consultation, and we saw no difference in side effects in the 2 groups. Yeah, in our study, we saw that it worked on women with episiotomy and second-degree tears. We also wanted to evaluate if this result was only driven by women with high-risk profiles for complications. That could be episiotomy, instrumental deliveries, and high BMI. So we decided to conduct 3 sub-analyses with women without episiotomy, without instrumental delivery, and without high BMI. And we saw the same significant decrease in relevant wound complication across the 3 sub-analyses. So it looks like that antibiotics works on all women with episiotomy and second-degree tears. We have at our department at Herlev Hospital in Denmark decided that the women should know this and they should be able to choose the prophylaxis, and therefore we have implemented it as a standard of care. Our result built upon a large UK trial, the ANOTE trial, that evaluated 1 dose of IV antibiotics for women with instrumental deliveries. They looked at infections, but they also found that for wound complications specifically, they reduced the risk significantly by providing 1 dose of antibiotics. And the WHO have changed their guidelines accordingly. Our results does not contradict with the ANOTE study. It built upon them and it broadened the number of women that could potentially benefit from this treatment. However, of course, it is always important when we are talking antibiotic studies that authorities and healthcare system in other settings compare the settings that we have performed this study under with their own setting regarding obstetric settings, regarding bacterial and resistant patterns. But when this is said, we believe that we have 2 RCT studies using the same antibiotics from UK and from Denmark, and they both find the same beneficial effect. So we believe that supports the use of this in other obstetric settings as well. The next thing we are going to look into is how clinically relevant wound complication affects the health of the women after a year. We also had a 1-year consultation, and we're going to see if incontinence, prolapse, sexual health, and body image are affected after a year when we compare women with a clinically relevant complication to women without. Further, when we did the systematic review, we saw that there was an issue regarding definition of wound complications. There were so many different definitions used, and none of the studies didn't even have a definition. When we designed the repair study, that was a challenge, and we decided to use 2 different definitions. So we had a broad overall definition with infection and wound adhesion above 5 millimeters. That seemed to include too many women that actually were doing quite good and only had a superficial adhesion, probably part of normal healing. Then we also had another definition, clinically relevant wound complication, defined as wound complication that needed further follow-up based on the size of the adhesion, infection, or pain. We believe that with this definition, we captured the relevant complication quite effectively. But we also recognize the need for a comparable, easy-to-measure definition to use in future research. So we hope to go back to our 1-week data and evaluate if we can come up with a meaningful cutoff value for wound adhesion that could potentially be used in future research. Yes, thank you for letting me come with a final remark. We are, in our group, very surprised about this high frequency of complication, and we are shocked that it has retained such little attention until now. Suturing after obstetric tear are one of the most commonly performed surgical procedures worldwide, and yet it is one of the most understudied. And we hope that that will change in future research.